this virtual dissection on the computer using a very low cost 3D tool. So this is going to be very interesting. All of us could use this technique to get these beautiful images as we can see here. Then on the 12th of July, we are going to have Dr. Silverman finishing his series of this semester, and he's going to talk the second part of his talk about the imaging, correlating imaging and morphology with the functionally single ventricle. And then in the end of the month, on last Thursday, 29th, we are going to have our fetal series. This is going to be awesome as well. And now I'd like to introduce Dr. Kaze Kulberson. He was the one who thought about this webinar and placed all of these great speakers together. And he's going to start this webinar for us. Thank you guys for participating, and thank you, Kaze. You are still muted.
You think after a whole year we'd figure this out, you know? So I'd like to thank Grace, Sasha, and Gil for allowing me to organize and also to present at this webinar, and also to all the international speakers who are participating and from whom I've actually learned a lot over the course of the years. This webinar kind of came about, I like to call the subtitle of this webinar, Gil's Fault, because Gil was actually doing one of the CHA webinars about transposition, and he put up a bunch of possibilities as to things you could do for the patient. And I looked and I thought, that's great, except I bet in the vast majority of the countries, none of these are options. So that's how this webinar came about. I think we're going to start off with Sasha giving us an overview of how can the developed world support CHD programs in emerging, or what the World Bank now likes to call low middle income countries. So Sasha, if you want to start.
Yes, thank you, Casey. I agree with you. When we start with the experience with the Congenital Art Academy, we never expect to reach such a fantastic and really exciting experience all over the world. So thanks again also for your idea and your support. I want to talk of something that I really experienced in my life, and I hope will be very more easy to talk about what you experience in 20 years on voluntary about congenital heart disease all around the world. So here we have some data that is, of course, mostly an estimation rather than concrete or complete data. But we can really understand out that in more than 90% in the low and middle income countries of the children doesn't have a real adequate access to the cardiac care. And more or less we can say this, but there is a lot of fantastic speakers after me. We can talk about this. 250,000 people, children between 5,000 to 300,000 of children die every year because they cannot not only access to cardiac care, but can receive an operation for congenital heart disease. I don't have disclosure, and I use again some experience from the academy when Bill Novick told about the experience of Novick Cardiac Alliance. And of course, I think that one of the first points that we have to underline in order to understand what we need, what the people, what this country need from us. Here in this fantastic paper, we can see how the numbers on the left side of the screen, you have the low income countries, and the right side we have the high income countries, and we can see very easy how the difference about adult cardiac surgeon in blue, and in red we have pediatric cardiac surgeon. We can say that in low income countries we are not able to see neither the blue or the red, and we can better understand, come inside how the problem comes in this field. And again, in the same paper, the colleagues was able to, screen the problem also from the GDP of the country. And here you can see very easy that, on the top of this graphic, we are able to understand how in North America and in Europe we are able to have a great number of cardiac surgeon and pediatric cardiac surgeon. But when we look to the left side of this graphic, we can say that in sub-Saharan Africa and South Asia, we have more or less 0.1 pediatric cardiac surgeon per million of inhabitants. And this is, I think, very important in the general consideration. And here we go. If we look again to the distribution all over the world, the number, of course, this data come from CTSNet, so mostly of the colleagues that are registered or that have access to internet, and of course they are registered to the CTSNet, that is our network for cardiac surgeon, cardiothoracic surgeon. And again, we can see how the North Africa and Middle East, the number of pediatric cardiac surgeons are very poor, and mostly in sub-Saharan Africa, we really don't have human resource to support such a program. And this comes from Bill Novick, and again, his evaluation about the annual live births per year. And again, very interesting is the number of cases that we have in the Middle East, and with a very huge number of newborns. And of course, this is directly connected to the surgical activity, to the number of cases that can have congenital heart disease. So again, I'm very impressed about this number, and I'm very happy because both Krishna and Parvati are here, so that we can make, I'm sure, some comment about this point. But what about the magnitude of this type of support that we are able to do to help this country? This is a fantastic paper review. I want to drive your attention in the lower part of the graph, and you see the incidence rate between 90 and 2017. It remains about 25% per 1,000 people born. So we don't really have a change in mortality and trend in about the congenital heart disease all around the world. I think this paper is very important because I'm sure people feel that we have to do a lot in support on improved strategy for this country, but you can see how the difference in mortality doesn't change during this big period. And again, the mortality and the incidence are again related to in the global and regional national level. We can see how during these two huge periods, we see an increasing number of congenital heart disease, and we see an increasing in mortality, probably because, again, we see a huge increasing number on the newborn or the live newborn in this part of the world. And again, this make the sense of also our activity. This is a photograph about the number of colleagues in North Africa rather than in South Africa. And here the situation is about more or less 100 cardiac surgeons in the north of the Africa rather than about 35 adult cardiac surgeons. The paper doesn't have the the separation about cardiac surgeon and pediatric cardiac surgeon, but this trend, of course, confirm how the first point of the activity is really limited by the number of patients. So I like to share with all of you this consideration, but I'm sure that is thing that everybody knows. And I think that probably we can discuss point by point, and we can learn one from each other. So I'm very happy to start this series with the Congenital Heart Academy with Casey, because I think that there is a lot of things that are not really clear and not easy to manage in the strategy to support this country, because of course economic factors and the lack of a training center locally, everything is over the table, but at the same time, every time is not easy to access and to help in the way the people needs. And this is very important for us that wants to help. And I think that make the sense of this meeting. So I have my idea about this way to support, and I call this the selection rule, because I learned from the experience that sometimes you choose the wrong country with the wrong center with a good team, you choose the wrong patient to treat, and of course the wrong strategies to apply to this country. So I think that selection is one of the main points of the results, or to achieve something that the people really need in this country, or this area that are difficult to access. And again, my personal perspective, what I learned, these people, this country doesn't need surgical show. What I think that this surgical show is to go there, to do a lot of case, very happy to leave the patient in the ICU with problem, with drain, and doesn't make really help people with the support and train them on the job, stay with them and try to improve the level of activity. And again, I think that it's very important to tailor program according to the requirements, center by center. And of course, it take times, but at the same time, there is a lot of to do with this type of strategy. Regarding the third point, sorry, but we are very happy because the Academy, for the first time, free of charge, without any economic support, was able to stay close to people and to send a message with the amazing speakers, the best speaker that was possible to have during pandemic period, to have sort of continuing team education regarding mostly, of course, anatomy, surgery, and of course we cannot help at the moment on practical things, but I'm sure Gil and Grace have a lot of idea, and of course no limits in improve the support. Again, I think that selection and looking to the patients that can be really helpful for the country is very important. And the strategies, I want to share with you the strategy of the pandemic period. We were able to accept in our center for people, from colleagues from Palestine, from El Salvador, from Uruguay, and from North of Africa to stay with us rather than to come there and doing the operation. So we are very happy for this. I hope that in 1 year they will be able to improve the quality of assistance when they come back. This is our, when I look to Gil, to Bill Novick, this is nothing about we do, but we can share the experience from Tanzania, where we were able to do for 5 years, year by year, we were 2-3 times there, and we are very happy now because they are very they are able to continue the program. We are working a lot with Libya, with a group of Bill Novick, and trying very close to us, trying to improve the quality. We were in Salvador. We don't go more in Salvador. They are very happy now. They are making a lot of good things. I'm very interested in support sub-Saharan team. So we are going to Botswana, Namibia, and working together. We have the big privilege to visit India once in Madurai, and to help and support a young colleague in improving his results. So thanks again for this case and for these topics. And I think that when we go around the world, we have to consider first that we are lucky, second that sometimes they don't need what we feel they need. So we have to talk with people, try to understand this. And I think that I met a lot of beautiful mind all around the world, and our mission is, of course, to support the child, but at the same time make this beautiful mind available to the world. So thanks a lot, and I think that Casey will be able to improve and to concentrate more on these topics.
So Sasha, thank you for that great overview. Let me start this and then share my screen. Quickly, which is right here. And there we go. You can all see that?
Yes, perfect.
Yeah. Perfect. So I'm going to talk next on the basic principles of developing a congenital heart disease program in low middle income countries. We're going to switch the program around a little bit. Grace is on service in the ICU and it's a little busy for her, so she will follow me after I'm done, and then it will be Marcello Kozak who will speak about echo, well, actually imaging in low middle income countries, and then Dr. Krishna and Parvati Iyer will talk about both surgical skills and ICU skills needed. So let me just get started. First, I labeled this talk principles, but the reality is this is really lessons learned. It's not really principles. So this is what I've learned from developing open heart programs in Vietnam for the last 15 years or so. Financial disclosures, none. I have a gastronomic disclosure that I'm a big fan of pho. The best pho I can find is on the sidewalks, either in North or South Vietnam. An overview. So this is kind of a timeline from 2005 to 2021. I'm doing this a little bit like my friend Bistra from Children's Heart Link. They have a series going on at the same time that I thought was excellent and kind of covering topics that are important. So 2005, we'll talk about the status of what I found in Vietnam when I first got to Ho Chi Minh City, also known as Saigon. What were our initial challenges between 2005 and 2008, our initial ideas and NGO collaborations and program building. 2011, kind of we look back for over 5 years, what lessons did we learn? Kind of now what's our ongoing results from collaborations? And finally in 2021, what's new challenges and opportunities for pediatric cardiology and cardiac surgery? If this sounds like a lot to conquer, one of the things I learned from one of my mentors, Joe Perloff, was the mind cannot absorb what the butt cannot endure, so I will keep it short. And also the other thing I've learned from, I think, every congenital heart surgeon I know is CHD always comes in threes. So I'm going to try to bundle a lot of these ideas into threes. So a quick tour for the history of congenital heart disease surgery in Vietnam. Vietnam's a densely populated country, over 95 million people, obviously in Southeast Asia. The World Bank considers Vietnam a low middle income country. About 11% of the population lives below the poverty line. And if you look at the two graphs, you can see that Vietnam essentially has an expanding population with a declining infant mortality rate. Now for CHD surgery, the average cost for heart surgery there is somewhere between $1,500 and $4,500 US. Interestingly, the central government actually provides financial support. So if you're under 6 years old, basically the government pays for your heart surgery. Unfortunately, this is not completely consistent, but it's a really excellent program. And in the early 90s, congenital heart surgery really took off, at least in the Ho Chi Minh City area, with the development of the Carpentier Heart Institute by Professor Alan Carpentier. It's a beautiful place. And literally when I got to Vietnam, it was kind of the only game in town. And that's a picture of it in the lower left-hand corner. So how did I get involved? It seemed pretty simple at first. I just got asked in 2005 by one of my neonatology colleagues, would you train a Vietnamese doctor in post-op ICU care? And I said, sure. Then it got more complicated after that. So July of 2005 was my first trip to Vietnam. January of 2020 was my 29th trip to Vietnam. So the first thing I can tell you, if you're going to develop a program, it's definitely you need to have boots on the ground. The first program I went to was in Ho Chi Minh City. It was Nhi Dong, or Children's Hospital number 1. By 2013, I had gone north to Hanoi at the National Children's Hospital. At the same time, I helped co-found MD One World, which was a website that was dedicated to kind of educating our pediatric cardiology and CT surgery colleagues, and they had the ability to post cases, educational tools, etc. So in 2021, I seem to be working with about 7 hospitals, the 3 children's hospitals in Ho Chi Minh City, along with the University Hospital, Women and Children's Hospital in Da Nang, which is in the central part of Vietnam, and the National Children's Hospital and Hanoi Heart Hospital in Hanoi, which is in the north. This is another one of these things I like to call Gil's fault. We're actually building a cardiac care research consortium to look at new cardiology research programs. And I also decided when I was putting this talk together, I'd become very facile at how to get to Vietnam. So if anybody has any questions how to get there, just ask me, because I think I've done it about every which way possible. So what did I find when I first got to Vietnam? This is kind of personnel. So for the doctors, you had 6 years of medical school and you could immediately practice medicine. There's no such thing as a true residency or fellowship for specialty training in pediatric cardiology or CT surgery. There was a lot of see one, do one training with minimal supervision. And most of these guys and gals literally had to moonlight in private clinics to make ends meet. So at 4 in the afternoon, they were running out the door to make money for their family. So the result of that was you had extremely bright, enthusiastic 24 and 25-year-olds who literally had no experience running cardiac ICUs and making treatment decisions. They had kind of minimal learning time or structured learning. There was variable attending level support because they were also running out the door to do clinics. So what ended up was significant mortality and morbidity. For the nurses, there's also a significant lack of CV ICU nurses. We're used to, in the United States, ratios of 1 to 1 or 1 to 2 for patient RNs. In Vietnam, it was more like 1 to 5 or 1 to 6. I could find no RN ICU training, so there's no mentoring system. And again, the result was significant ICU morbidity and mortality. In terms of the physical plant, the Nhi Dong One Children's Hospital at the time was a 1,200 bed hospital in the middle of Ho Chi Minh City. It served about 32 million people. It was a 55 bed cardiology ward, usually with about 88 patients on the ward in the hallway. And this is interesting, as you see on the left bottom, that's the hallway to Nhi Dong One, but those are actually all patients admitted to the ward. They had multiple intubated patients on the ward with what I call parent ventilation. So mom and dad or grandma were squeezing the tube or squeezing the bag. They saw somewhere between 100 and 125 new kids a day. 95% had congenital heart disease, and many had conal truncal abnormalities, so TETs or transposition, just out of proportion to anything I'd seen in the rest of the world. And that's important to remember for this talk. At the time, they had a 4-bed ICU with, but really 2 beds being used. And this is what parent ventilation looks like right there. So what we found was a backlog of over 5,000 patients with 2 ventricles requiring surgery. It was the usual suspects, primarily ASDs, VSDs, and TETs. All were expected to have a good outcome, all required probably just 1 intervention, and they were, most of which were going to be paid for by the Vietnamese government or the NGOs. There's no cath interventions at the time I got there, and then there were a handful of single ventricle patients with persistent PVAs. So we made the decision that we would not operate on any single ventricle patients due to the backlog of the 2 ventricle patients and the limited resource. This is kind of a decision that came back to bite me a little later, but we thought it was the best at the time. The third part was the things that I took for granted. So medications. Prostaglandin was essentially non-existent. Milrinone was extremely limited and very expensive. the infrastructure, the echo machines were absolutely antiquated. There were no TE probes at the time. There was no cardiac CT or MRI. X-ray was quite slow. There was no point of care testing, inadequate cardiac monitors. There was no blood bank at the hospital. So surgeries would wait sometimes till the family donated blood. There was absolutely no follow-up or outcome metrics. There was, like I said, no formal training. So people needed to be trained or retrained. And then there is a lot of late presentations of kids that were very cyanotic or polycythemic. I learned a lot about cerebral abscesses in my first couple of years there. There's also this famous pneumonia. And these kids would show up with incredibly resistant bacteria because they'd been on multiple antibiotic courses prior to presentation. A lot of kids showed up with stripes on their sides or backs, and we had no idea what the cardiac surgery was. And then it was finding the funding for kids greater than 6 years old. So I decided the best place to start was taking the three things I know to be true everywhere in the congenital heart disease world. That was one, nobody dies in the operating room. Essentially 100% of the mortality and morbidity occurs in the CVICU, and that the shortage of experienced and skilled nurses and doctors severely impacts the CVICU patient outcomes. And from that, I actually found really one important rule, and this is probably the take-home point from this entire lecture. It turned out to be Casey's rule number one, that you cannot blindly impose Western standards onto the Vietnamese medical system. And for this webinar, you could probably take Vietnamese out and put in any low middle income country's medical system. What works well in the United States may or most likely will not work as well or with the same results in Vietnam. So for me, I had to learn the art of compromise in the Vietnamese medical system. And that, of course, required three things because I needed to learn to understand Vietnamese thinking. It's actually pretty simple. So you ask a question, do you understand what I am saying or doing? If the answer is yes, that means yes, they do. Yes, yes means maybe I do. And yes, yes, yes means not a clue. So that became another rule I learned, the Vietnamese universal request, which was repeated to me more than 3 times, was Casey, speak more slowly. So what we came up with was a consensus of how to do surgery. We called it the 3 table leg paradigm for patients undergoing congenital heart surgery. One of the first things I found that was interesting was the idea to introduce the idea that care of a surgical patient was a key team event. The equal voice idea was just an incredibly foreign concept to them. So we ended up defining team roles and expectations. So for the cardiologist, basically is you had to have the absolute accurate diagnosis before the child went to surgery. So that was the synthesis of echo, x-ray, cath, angio, CT, and MRI later. And then actually at some point we got a TE probe and that helped. That then passed on to the CT surgeon who had to make the best hemodynamic repair possible. So holes closed, outflow tracts open, valves repaired. We actually did TEE and TTE to make sure there was no significant residual lesion. And that was extremely helpful for the next phase, which was the cardiac intensivist, where we did aggressive IC organ-driven system care. So we tried to create practice guidelines or flight paths, whatever you want to call them, doing morning rounds and establishing 24-hour care plans and attempted early extubations because the CVICU infection is just a huge issue. So a few things I discovered in the early years, the Casey's ideas, start big, go small, that wasn't exactly novel, but it actually worked well for us, to bigger weights to smaller weight, years to days, VSDs to neonatal transposition. One thing we did do, which I found extremely helpful, and I think the Vietnamese did too, is when it come to Vietnam, we would focus on a specific lesion for each trip. So to the best of our ability, on one trip, we'd operate on tetralogy or AV canal. And the learning curve is extremely good when you're doing the same lesion like 5 times in a row. We never operated on the most complex kid last, and we didn't leave till everybody was stable. And I just determined never to bring a child to the United States for treatment. It's prohibitively expensive. And my Vietnamese colleagues would learn nothing if the child went to the United States. My discoveries were never violate important rule number 1, try to think like your Vietnamese colleagues. And talking louder and faster in emergencies resulted in absolutely nothing happening, something we called the freeze. So we stopped doing that. Some new rules, my Vietnamese colleagues are just married to their cell phones, and we had to get them off their cell phones in the operating room. That took a little work. Cyanotic patients, especially TETs, we had to have the pump ready and surgeons nearby prior to induction. We instituted the timeout for each patient in the OR. As many of you know, half the country is named WIN, so we needed to make sure we had the right WIN on the table. We needed to have metrics, so we instituted a database. And in the Cvic, which was an interesting, again, foreign concept to them, if you didn't understand what was going on, you did an echo. So one of the best collaborations we had, so this was in early 2008, was with Children's Heart Link, and I think many of you know BSTRA. And what that brought to the program was training. So Children's Heart Link was able to bring teams from the United States, and especially from Singapore, which is only about an hour and a half away. Mary Tan, who's one of the nurses, was absolutely instrumental in helping the nurses in the cardiovascular ICU. Children's Heart Link also sponsors and sends doctors and nurses abroad to train at sister institutions. And it turned out in 2013, Children's Heart Link began a partnership with National Children's Hospital about the same time I went there. The other thing that happened at the same time was the Boston Children's IQ project, which actually gave us metrics. So we could collect data and look for ways to improve methodologies and collaborations, obviously between programs in these emerging countries to reduce mortality at various sites. So what's the results of all this? So in 2011, we published our first 5 years in Congenital Cardiology Today. 633 patients, 98% were on bypass. The big three were VSD, ASD, and tetralogy of Fallot. So our overall 5-year mortality using this 3-table leg paradigm was less than 1%. The median age started at 28 months, but it got the children got much younger as time went by. Median weight was 9.2 kilos. They got much lighter as time went by. There was a definite trend to more complex repairs as time went by, and PDA stenting became much more common as well as interventional ASD and VSD closures at the end of the study period. In terms of Icu complications, almost 50% had actually no problems. There was 41% or so that had this famous pneumonia, which was just a code word for infections. And so we had to do a little training on infections. At temperature at Nidong 1, over 38 degrees, even on post-op day 0 to 1 was considered a fever, which could start antibiotics. An abnormal chest x-ray, which was often a pulmonary edema, not true pneumonia, was an infection. A pneumonia resulted in prolonged intubations, which would turn into a week or weeks. Empiric antibiotics, especially vancomycin, was often started without cultures or other supporting evidence that would go on for a week or weeks. And if you're on antibiotics, you had prolonged indwelling central lines that went on for a week or weeks. So the things we have learned since that time is, one, conserve resources. So we became early PDA stent adopters because of the lack of PGE. Milrinone we use very sparingly. The infrastructure and patient management, with the limited ICU bed space, we found better ways to do patient throughput. And the practice guidelines or the flight plans were the key. We very much limited antibiotic use, especially vancomycin. We attempted earlier extubations using diuretics and extubation readiness tests, which led to less infections. And I started them with the "do I need this" test. So every day you ask the question, do I need this? Ventilator, central lines, et cetera. This resulted in decreased central line times and less infections. And actually, what I liked about this, and I think what's interesting, is I learned something in return. So I brought home to my ICU the "do I need this" test. I watched my Vietnamese colleagues get the same results that I was getting, but with much less chest x-rays, blood gases, chemistries, et cetera. So when I did this in my unit, I found about a 25% decrease in resource utilization. So I thought that was a fantastic interplay between two programs. So let's fast forward to about 2020. This is results that were given to me by Dr. Zhao at Nidong 1. They did 437 cases in 2018. Their mortality is still less than 1%. Notice that their postoperative days and CICU days are now measured in days, not weeks, or day and not week. I think that the arterial switch operation is the real gold standard for knowing if your program is developing and how, technically challenged and how you're doing. So I asked Dr. Zhao to send me 4 years of data. For straightforward ASOs, it was about 6.3%, surprisingly 4.3% for slightly more complicated TGA with VSD. And when we looked at what was considered the kind of the benchmark, this was published out of IQIC in 2028, their range was from 10 to 25%. So we're quite happy with the results at NEDON 1. When I went north to National Children's Hospital, this is from Dr. Trong. This was 2018, where he did about 1,300 cases. I think the first thing you can note is my idea about single ventricles has completely gone out the window. His total his total mortality was about 3.8%. Looking at arterial switch, 2.1% for straightforward arterial switch, 3.3% for TGA VSD. And interestingly, again, in another kind of benchmark paper, the survival was pegged at 85%. So obviously, National Children's is doing quite well. And so what are our challenges in 2021? Well, the first one is expand MD and RN and nursing training in person. The challenge here is if you come to the United States, you really just look. There's no hands-on experience. You can bring visiting teams, that's limited teaching time. Online training, obviously, in the world of COVID has been very good. But Children's HeartLink has really been key to getting my Vietnamese doctors trained. And this is kind of ex-Vietnam training in preferably Southeast Asian sites. My only kind of still concern is I'm sending these young cardiologists abroad and leaving their young families at home for extended periods of time, but the Vietnamese have seemed to adapt to that. I consider this kind of training opportunity priceless from Children's HeartLink. Here's just a list of some of their centers of excellence that are nearby, certainly closer than the United States. We also, as you can see in the past, through my work with NEDON 1, have done in-person teaching, and you can see my friend there, Norman Silverman, has gone to Hanoi and Ho Chi Minh City. The Vietnamese absolutely love Norman. He totally violates the speak slowly rule, but they don't care. And obviously the new player on the block, which I think is absolutely key and important, is Congenital Heart Academy. Our second challenge is to train enough CVICU nurses and give them a voice. I actually asked some of my cardiology colleagues what they thought of their nurses. And the one that disturbed me the most was the CVICU nurses don't have knowledge about congenital heart disease, but doctors don't share their knowledge with the nurses. So if you look to the right, there's a picture of me pontificating, I think at the National Children's. Down below, that's my friend Wyman Lai at NEDON 3. And the question that got me when I looked at this is, where are the bedside nurses? Why are they not involved in the bedside teaching? So that's something we need to focus more on in the future. The third is the CHD screening and funding from NGOs. I've had the privilege of working with Vena Capital and Heartbeat Vietnam since soon after I got to Vietnam in 2005. They do a lot of screening. They've screened over 250,000 kids since 2007. I think they've been to almost every province in the country. You have found over 8,000 kids requiring surgery. In 2020, they went to 14 provinces, 143 outreach clinics, so literally almost every month or every weekend. They found over 51,000 kids, found over 650 kids with that needed surgery. And they have a fundraiser called Scar Life. And to date, they've funded over 8,000 kids open heart surgery. And these are the kids that are over 6 years of age. And this became an interesting thing for my last point, which is using this data, we've been able to do some interesting research in Vietnam. So this is the newest challenge. The first one was the arterial switch and acute kidney injury. This is another one of things I like to call Gil's fault. Gil presented this paper as part of a transposition lecture he was doing at Congenital Heart Academy. And he showed this where a UK study had 71 patients collected over 10 years and a little over half developed AKI. Well, as I was sitting there watching that, I thought, in Vietnam, the combined output of arterial switch operations is probably over 75 cases a year. So we put together this Pediatric Cardiac Care Consortium, and it's our first kind of attempt at a collaborative effort a prospective study looking at the same question about AKI and TGA, and hopefully we'll present this at the 2023 World Congress. The other interesting association, and this came out totally by accident, is the potential association between Agent Orange and congenital heart disease. So as many people know, the United States sprayed Agent Orange over Vietnam between 1961 and 71, over 72 million liters. And while the Agent Orange is actually gone, what's left is this byproduct called dioxin, which is incredibly toxic. And that works its way into the food system and then ultimately ends up causing some birth defects. And one of the interesting things I found when I was preparing a lecture for the Vietnamese was this article that said maternal exposure to any pesticides or herbicides during the first trimester is associated with TGA in their infants. Well, as I said before during this presentation, the amount of conal truncal abnormalities I've seen in Vietnam is just out of proportion to anything I've seen in the world. So I asked my Vietnamese colleagues to send me their conal truncal abnormality data. And it turns out in 2019, Dr. Liu published some global prevalence data for TETs, transposition, double outlet, and truncus. So I put that all together with our Vietnamese data, and that was over 9,600 cases. And you can see that the incidence is almost double. And when we did the statistics on that, that seemed to be statistically significant. So that brought up another question. Well, if these incidents are higher, why is that? And that's led to an interesting collaboration with some soil scientists that I've met called the Mary Banner Retirees. These are doctors that have gone to Vietnam and sampled the soils because we're trying to figure out why is it that this dioxin may still have an effect over 50 years later. As you can see, it was Agent Orange was sprayed over Central and South Vietnam. We're actually in the process of developing a CHD prevalence map to see if we can match up where Agent Orange was used in the prevalence of congenital heart disease. One of my colleagues in Da Nang, we've already looked at, Da Nang was a hotspot because Agent Orange was stored there and loaded there. We found that the prevalence of congenital heart disease there is 3 to 4 times higher than the published Liu data. And our first kind of blush at looking at the data between Central and South Vietnam shows those incidents to be much higher as well. So again, this is something that could be presented at the World Congress when we get all this data together. So with that, I'll stop. I will thank all the participants for listening. I want to thank my Vietnamese colleagues for putting up with me all these years. And I think the one take-home lesson, if there is a lesson to be learned, that we all work together very hard. We have a good time together. And I think the good thing is we really don't take ourselves very seriously. So thank you.
It was an amazing talk. Thank you very, very much. It was very nice to listen to you and to Sasha talking about how these mission trips can make a lot of things for the population and for the healthcare providers who are there taking care of these kids and can learn and can start to do things by themselves later. It's very, very nice to listen to that. Okay, I'm going to talk to you guys today. And I'm going to talk about how to build an ECMO program. And I like to use this word successful. It's not on the, exactly, it was not the title of my presentation, but I think everything that we do, we should do with excellence. And even if we are on a low middle income country or an emerging country, as I was in Brazil, we can try our best to do things with excellence and to achieve the best for our patients. So I have no disclosures. And all the pictures that I'm using, when there's patients there, the families are aware and they gave consent. So the first thing that I always think about, what the word successful mean. So you have to have a good outcome. So this is a picture that the mom published on social media saying, my name is Clara and I was saved by ECMO. So this is a post-ROS procedure patient who had cardiac arrest and was placed on the ECPR and survived with no neurological complications. Another thing is that when we measure the success of our program is that the family and the patient, they need to have a good experience. And this is another ECPR patient being discharged from the ICU to the ward. And you can see that the video is not 100% okay yet, but the parents, they were so happy with the outcome. And of course, we have to think about money because someone has to finance everything that we're going to do. So what I'm going to talk to you today a little bit is a very practical approach. I'm actually telling you a story. As Casey just talk to us. I'm going to tell you how we developed our ECMO program in Brazil in 2015. So we started, I think everything that we start, we have to have something to push us to do that. So we had the TJ patient that was on the OR, was not able to win from bypass, and that was it. So all the team, when we were debriefing the case, we found that it was absolutely heartbreaking that the patient didn't get the chance to be on ECMO for maybe 2-3 days, and maybe he would have survived. And so we decided that maybe would be the time for our program to have an ECMO program. So, and this, I found this publication from PCCM 2013 when I was preparing a talk like this in, I think it was 2018. So when we started the program, I haven't read this publication, but in an organic, spontaneous way, we kind of followed what was written there. So we started with the Motivate experts. It was only 3 pediatric cardiologists that really wanted our patients to have a better outcome. We talked to the hospital, so we had the institutional commitment, and then we developed an interprofessional team and all of us dedicated time, space, and resources to this ECMO program. So if you take a look at also tell us about how to develop a ECMO program, they give some recommendations. And this is a very nice paper. If you're thinking about starting your ECMO program, take a look on the ELSO guideline for ECMO centers. For sure, it's going to be a big help. So they say that you should have an ICU on your hospital, should be a tertiary hospital, and you should probably be able to run at least 6 cases per year. Otherwise, all the investment and especially the training would be for nothing, because less than that, you can't keep your expertise in a good way. So when we decided to start our program, we look on that guideline, but we did something a little bit forward. We looked, so it also has an award of excellence. So they acknowledge the centers that do ECMO in the best way as they can. So when we started the program, we look at the guideline, how to make it, but we look at what would require us to achieve the excellence and to achieve the award from ELSO. So since we started the program, we try to achieve all of these. And if you go to the website of ELSO again and take a look what it requires, it doesn't require money. It's not about having to pay something different, to have the most amazing equipment. And no, it's all about processes. It's all about procedures, your policies, how you're going to build, how you're going to take care of the team, how you're going to take care of the patient. So it doesn't require an extra amount of money or extra resources to achieve excellence. You just need to focus on that. So this is what the paper from PCCM tells you how you should develop an ECMO program, and how this is how we did it in Brazil in our program. So first we decided what would be the scope of our program and we were planning. We started thinking about mostly the cardiac patients. In the end, we really looked at it because our program was mostly use it for septic shock and respiratory patients. We have a very big ICU on that, on my former hospital. So in the end, we use it a lot, ECMO, for this kind of patients as well. So we went to Canada, to the Solar Children's Hospital, 2 physicians to have initial training. We got the ELSO protocols and we adapt to our reality, and then we affiliated to ELSO right away. So how we started our program. We had the help or the support of the hospital administration. They understood that it was an important program for the hospital to have. And more than helping us to get the ECMO console or some equipment. What is important that hospital to understand that is important to give us time of the practitioners to train, to be retrained. I think that was the biggest help that we required from the administration of the hospital and that we achieved. So we could train the nurses, we could train the physicians, we have that help to get the time of the providers to be trained. And we started with a very basic team, the surgeon, a few nurses, a few intensivists and cardiologists, and one perfusion. But what we had, and that's something that I truly recommend you to get, is a chain of help and collaboration. This is going to make your learning curve to be much better because you use the expertise and the knowledge of the others on your own program. You don't need to figure out things by yourself. You can ask your colleagues who are much more experienced than you. So that's what we did. We had this close collaboration, and with Solid Children's in Edmonton, in Canada. And I need to always to say thank you to Dr. Daniel Garros, who is my mentor and who helped us a lot, like answering phone calls on Christmas Eve about a patient that we are not sure what to do. So this is something that I really think this is very important to have people more experienced and with more knowledge than you to help you to figure out things. And we got very close to another hospital, a public hospital in Brazil that was close to us, and they already had an ECMO program. So we were very humble and we talked to them, and they gave a lot of help. They were amazing. And we were very close to ELSO as well, starting with ELSO Latin America and then with the global ELSO. So it helped us a lot. So then we decided about the equipment, which console to buy, which console to have. We had the joint workforce in the hospital with everybody involved, OR, CICU, pharmacy, radiology, blood bank. And this is something that is known and even published in the literature, that when we start an ECMO program, all the hospital gets better because you increase the complexity of your patients, and everybody get involved and try to get better, so you have better results on the other areas as well. And then the other thing that we had to do is to adapt the things that we already had, because we couldn't buy everything. And some of the things, even if we could try to find the money to buy it, they were not available in Brazil. For example, we have the Spectrum machine that is the inline blood gas real-time monitor that we use for ECMO. We don't have that in Brazil. So we have to think how we could do that. So we decided to use central venous catheter with the saturation probe, and that this equipment we already had. So we use that to have our venous saturation real time on ECMO. And for example, we didn't have anti-10A that all around the world people use it to monitor the anticoagulation, but we have ACT, so we use it ACT. So we try to adapt what was possible in our country. And then we started the first case, this beautiful girl, and we are scared to death. And but it was a nice start. She survived. And so what we did, we got a perfusionist 24 hours at bedside, one extra physician on the ICU to take a look on the patient, and everybody to discuss together and think about it. And we had the set of basic orders, including the set of labs every 6 hours or something like that to make things better. And then we translated some of the basic ELSO guidelines so we were using. And we had a lot of lucky. I would say we were blessed by God, because our first 5 cases survived to hospital discharge with no neurological impairment. So that made the team to be very, very excited about ECMO and willing to learn more and to get involved with the program. So this is how the program developed. And when I left Brazil, we already had 18 physicians trained by ELSO training course. And we had another thing, if I can advise, if you're on your hospital, you have a lot of teams, for example, you have a lot of neurologists, choose one that is really interested in learn how ECMO patients are, and he would be your biggest help on that subspecialty. So what we did, we had some of our colleagues who were more interested or were closer to us, and they got really involved with the ECMO team, and we built a very, very big multidisciplinary team to take care of the ECMO patients. Then, so the program was running well, and we knew that we have to sustain what we achieved. So we focus a lot on training and education. So as I said, we sent a lot of our team to do the ELSO training course. We have an internal simulation and theoretical course as well, made by ourselves from the hospital to the team of the hospital, and everybody needs to be retrained once a year. And we have a series of lectures every month, so everybody could learn more. We had all the time we have to write a new guideline or new protocol. We use our monthly meeting to present that protocol or that guideline to the team and to ask for suggestions, so everybody would be part of the new guideline. And we develop a lot of checklists to try to be error-proof and to increase the safety of our patients. And I love this 2 pictures, because this first one is the first ECMO transport that we did to the CT scan. We couldn't even breathe. We were super scared. And this is another one after maybe 1-2 years of the program. We were even able to smile while we were with the patient in the elevator. So it means that we were much more confident with what we were doing. And then we started to add complexity to our cases. We were able to prone the patients. We were able to have the CRRT machine on the ECMO and the TPE, the plasma exchange machine, connected to the ECMO circuit as well. And we did a lot of procedures in our patients, cardiac procedures, cath lab, fasciotomy, abdominal surgeries. We had a lot of procedures during ECMO, so it came with time when we were more comfortable with what we were doing. So ELSO was always very important to us. We were part of the registry since the first case. We had no idea what we were going to report to ELSO. Well, thanks God it was a good result, but we didn't know. But we had this idea that we are going to send our data because we need to be true with science. And then we had in Brazil, which was something that was very nice, all the ELSO ECMO centers, they got together every 3 months to discuss. So we have these meetings of the Brazilian ECMO centers, and it was always very helpful. Everybody would help each other, give ideas how to deal with the specific things of our country. And we were happy to go to conferences about ECMO, and we are very happy to be invited to be to go to the course of the Train the Trainers. And so 2 of us, well, now I left, but it was me and another colleague, Larissa. We were able to now we can train people on ECMO by ELSO as well. And then we are very happy that we were invited to participate on the 30 years of ELSO. This is Esperanza. She's the first baby that survived ECMO, and I was very happy to meet her on this meeting in 2019. And moving forward, we needed to evaluate what we were doing. And we were very, very happy. In our minds, our results were amazing, but then we stopped to take a close look. So if you can see here, this is our results. Patients who had off ECMO and patients who had hospital discharge. And this is the ELSO comparison. So we were very good on all of them, but our neonates were not going home. What was going on? So we were losing all of our patients on the ECMO gap. So if we don't take a look, if we don't evaluate our program, you would never had realized that our neonates were not going home. So then we made a lot of meetings, brainstorm, and then we changed a lot of things and to get this result better. And it really worked. So it's important to evaluate what we are doing and to evaluate the long term of what we are doing as well. So as per ELSO recommendation, we have outpatient clinic to follow up the neurological status of these patients mainly. And then moving forward, we were invited to talk on meetings, and we sent abstracts to conferences, and we published our experience on pediatric septic shock. And so these things are important for you when you want to move forward. And then we did more things. We did our first primary transport. So we went to another city in Brazil to cannulate the patient and bring him to our center. This was our first extubated patient. And then we did our first air transport. So we went to a city that was 3-hour flight from our city to pick up this patient. And this is gorgeous boy, and his mom sent me a picture of him 2 days ago. He's doing super fine. And this is something that we're very proud of. This is not only the patient, we were able to extubate the patients. We were able, this patient, he was awake ECMO. Also, he was a 11-year-old patient that had fulminant myocarditis, and he was on peripheral VA ECMO, playing video game, eating and talking, and he had a good outcome. And so then after 3 years of the program, we were able to achieve the Award of Excellence from ELSO, and this was something that was very good for us. And what I like about this picture is that we have our perfusionist, our senior nurse, our surgeon, my intensivist, and myself as a cardiologist, all there. So we value a lot the multidisciplinary team. And if you want to do ECMO on your center, that's what you need. It's not about the resources, it's about to get people together, wanting to do the good thing and the right thing for the patients. Of course, we need more that you do, more you're going to face ethical dilemma. And this is one patient that we were removing from ECMO and on the lap of the family. And this is another patient that we placed on ECMO. The patient was a newborn, arrested. We were not sure what was going on. Then we sent him on ECMO to the cath lab. We saw that the only source of pulmonary blood flow that this newborn had was only this tiny pulmonary collaterals, and he didn't even have pulmonary arteries. So we talked to the family and discontinued that ECMO as well. So to deal with the ethical part is important when you move forward on your program. This is another patient. This was she was 9 weeks on ECMO, and this is the mom smiling, knowing that the next day we are going to discontinue ECMO because she was not a transplant candidate, and we found that the care was futile. And it was very hard to all of the team, but this is something that we are proud of because the team had a lot of support. We had a lot of meetings. The psychologist of the hospital talked to all the team before we were able to stop that ECMO. And for sure, this beautiful lady was feeling loved by her family and by the team. And taking care of the team is something that's important when developing an ECMO program. So we use it to go out together. After this, our monthly meeting, we would always go to have dinner together. We planned this parties to the first year of the program, second year of the program. And this is one talk that we had about moral distress, how important it is to support the team. And this is our beautiful team back home. And again, my take-home message that I want to tell you is that more than resources, you need to get people together to train and retrain and get everybody to understand what you're doing, how to do the best for the patient. And I'd like just to finalize to invite you to read this very, very elegant paper that my dear friend Jenna wrote, how she did it, how her team make their ECMO program in Lebanon. I'm happy to have Dr. Ihsan as a panelist with us today. He can talk more about it, but this paper is very well written and shows their experience and give us hope that even in low middle income countries, yes, we can do great things. And so this is how she placed in a very elegant way kind of everything that I'm telling you about. She wrote it, the team wrote it very well, and more than what they published is how they did. So it's a very nice program. So I invite all of you to take a look on this paper. And just to finalize, this paper was published a couple of days ago. It's not on pediatrics, but this is about how they started new ECMO centers during the pandemic, and in Middle East and in India. So what I want to bring you is that the new format ECMO centers, they, with appropriate supervision of the regional experts, were able to achieve good results. So again, when you're starting your ECMO program, use the expertise of your colleagues. Use what they already did, what they know, and learn from them and use on your program. And for sure, you're going to achieve better results in a shorter amount of time. That was it, guys. Thank you very much.
Grace, thank you for that excellent overview. That picture of everybody in the elevator with the ECMO machine just brought back memories. I had a Catholic kid who was on ECMO, and of course the cath lab was on a different level than the ICU. But anyway, so our next speaker is Dr. Marcelo Kozak. He's going to speak to us on training image basics needed for echo, CT, MRI for CHD programs in emerging low middle income countries. So he's been in the field of pediatric cardiology in Brazil for the last 20 years. He had his pediatric echocardiology fellowship at the Heart Institute of Sao Paulo and degree in health science by the Faculdade de Medicina de São José do Rio Preto, Brazil. He had a clinical fellowship in cardiovascular MRI by the Hospital of Sick Children's in Toronto in 2011 and 2012. Currently, he's a staff pediatrician or pediatric cardiologist at the Instituto de Cardiologia, where he leads a program of cardiac MR in children and adults with CHD and also performs echoes and works as an assistant physician at the cardiac PICU. He's also a pediatric cardiac echocardiographer at Hospital de Clínica de Brasilia. I'm just butchering all these words. He's an active member of the Society of Cardiac MRI and a member of the Department of Cardiovascular Imaging of the Brazilian Society of Cardiology. So please, Marcelo.
Hello, my name is Marcelo Kozak. I'm happy to talk today about training imaging basics needed for congenital heart disease programs in emerging lower middle income countries. I have no disclosures. In LMIC, limitations of human resources and facilities for cardiac surgery and post-operative management may adversely affect the outcomes of the pediatric cardiac surgery. Fate depending on birthplace PO box is just not fair. How are our regular days in LMIC? Well, this is a picture on the left of the Hospital for Sick Children in 2012. And here I have two pictures that I took yesterday here where I work, but in two different settings. In the middle one, you can see a very brand new equipment at a general pediatric hospital that doesn't perform cardiac surgeries. We do have complex cases there, but not so frequently. In the right panel, you see the equipment that is used at the cardiac PICU. You see that there is damage in the probe. So this is our reality, and you have to deal with that every day. This is the number of cases I've been doing, the number of cases of CMR I've been doing since I joined this program in 2015. 2015, there was the start. Then 2016, we improved the numbers. But then in 2017, the MRI scanner was out of order. 2018, we had roughly good number of cases, but then 2019, the number of cases was very low due to MRI scanner out of order or issues with the agenda. Then 2020, we have a regular year, even with the COVID pandemics. And this year, we have had hardware issues that made the MRI environment unsafe for sedated patients. So it's very frustrating. We would like to see ascending curve, but unfortunately, there is not much we can do as physicians. In the last month, I scanned just 2 patients, and there are 43 in the waiting list, but the health authorities simply don't do their jobs. Even scheduling a patient seems hard. The fundamentals for imaging congenital heart disease are the same for high-income countries and for lower middle-income countries. There is a need to understand cardiac anatomy. for the proper interpretation of clinical cardiovascular image. Sequential segmental analysis is the universal language and must be used. The imaging objectives are to assess anatomy, hemodynamics, and function. How to obtain a good picture? You need two components, people and equipment. Equipments are expensive. People are cheaper than echo, CT, and MRI. However, people have more value than both, and than all kinds of equipment. So the idea, if you want to build a program in imaging for a surgical problem, is to invest in people, education, and training. Put the right person in front of the right button. There are some scenarios that I have thought about. You can have good medical expertise and good equipment. You're gonna generate good quality in diagnostic imaging. The patient is in the right path and in the safe side. If you have poor medical expertise and good equipment, you have incomplete imaging. Your patient is in the wrong path and he or she is in danger. If you have good medical expertise, but your equipment is not good, you're gonna have an incomplete imaging, but you're going to stop, the patient still safe, you're going to redo your exam, or order another imaging modality. The patient comes back to the right path and is safe side again. However, if you have poor medical expertise and bad equipment, incomplete and poor imaging, the patient is going to be in the wrong path and in danger. The echo training recommendations in high-income countries are very well written. The programs are done for pediatric echocardiography. They are designed for pediatric cardiography. They are organized and headed by a pediatric cardiologist in a hospital with facilities for both inpatient and outpatient care in pediatric cardiology, and with neonatal and PIC units. These programs for pediatric echocardiography, they are linked to programs in cardiac surgery and catheterization. It is totally feasible in LMIC, and this is what I have seen in the places I've been working in Brazil. The echo requirements in high-income countries demand that a guy needs to have more than 1,000 echoes done and 75 tons of esophageal exams and 50 fetal studies to obtain the certificate to practice pediatric CMR in Europe and in North America. These people, they have ability to do more complex forms, to study more complex forms of acquired and congenital heart disease. This is also feasible in LMIC, but keep in mind that you have to accept some limitations. Not every practice has a TE Pro, and fetal echo is not regularly available for non-private patients, and at least in Brazil. The specialized level is the trainer, is the one that spreads knowledge. We have plenty of people like that in Brazil, and they have ability to supervise pediatric echocardiography studies, and they keep doing more than 500 exams a year. This is also feasible in LMIC, but also consider the same limitations. So why I'm talking about guidelines for recommendations of training? There's a reason for that. This paper published in 1999 that was carried on in USA assessed the diagnostic accuracy of pediatric echocardiograms performed in adult laboratories. And as you can see, the rate of errors in the adult side was very astonishing as compared to the pediatric errors. Out of the adult errors, 71% were interpretive. That means that these people may have acquired the images correctly, but they didn't recognize the disease or didn't interpret well. And this is very important. Many of these patients have their management altered, some going to surgeries, and some having averted surgeries, and this happens every day in Brazil, because we don't have a specific board exam for pediatric echocardiographers. Adult and pediatricians, they pass the same exam, and even if the fellow didn't have any experience with pediatric echo, if this person passed the exam, he or she is authorized to do pediatric studies. This other paper was published in 2015, and it was carried on in India. They compared the pediatric echocardiograms performed at primary centers and at a referral center. And they also found diagnostic discrepancies in 38% of the cases, emphasized the need for specific training and hands-on on a lot of cases, of complex cases including. So are these recommendations exaggerated? I don't think so. In this paper that was published this year in JACC, they assessed the impact of major residual lesions on outcomes after surgery for congenital heart disease. This was not the object of the paper, but it was there, so I found it very interesting. The rate of different findings in surgery during surgery was around 10%, even in these centers. So it's very important training. What are the CT training? How is the CT training for congenital heart disease? I myself don't have training for congenital heart disease, for CT, but I've been helping radiologists and cardiologists to do their reports. The training has two pathways, the radiology and the cardiology pathway. And they divide the trainers in two levels. And as you can see here, even the advanced practitioner, he has to have a few, not enough, in my opinion, experience in congenital heart cases. This person, they just have to do 70 cases of congenital heart disease, and I don't think that this is enough number to be exposed to the vast number of possible congenital heart disease that exist. This is totally feasible in LMIC, and equipments are usually broadly available. The CMR training in high-income countries is very similar to the training in echocardiography. You need to be a pediatric cardiologist or a radiologist. The CMR laboratory faculty should include a pediatric cardiologist who leads the exams. Needs to be at a hospital with both inpatient and outpatient pediatric cardiology facilities, there should be an active pediatric cardiac surgery program, echocardiographic surgery, echocardiographic laboratory, and also cath lab. The level 1 expertise has to have seen at least 50 clinical cases under direct supervision, but hands-on experience is not required. The level 2 expertise is the level required for practicing CMR imaging pediatric cardiology in Europe. These include active involvement in CMR interpretation under direct supervision of a level 2 or 3 trainer in at least 100 clinical cases. Is this feasible in LMIC? Not sure. Few centers can train fellows with these settings. The level 3 is required to lead a research program in CMR and congenital heart disease. The trainee should have hands-on experience in CMR imaging in at least 100 cases, has to be on continuing education, and needs to maintain at least 50 CMR image studies per year. So now you remember my number of cases per year. My capacity is 120, and my best year I had roughly 70 cases. The recommendations are very similar to the ECHOs. The COCAT4 task force recognizes that skills to identify basic and complex congenital heart disease in adults are usually acquired after 36 months of exposure to CMR cases in a general CMR setting. Therefore, it's advisable to concentrate the learning experience by training in specialized pediatric facilities where the number of CMR exams is quite the same number of surgeries. Is that feasible in MIC? Well, few centers can train fellows with these settings. Training abroad is expensive and very competitive. Last year, we published this paper that assessed the current use of pediatric cardiac MRI in Brazil. And as you can see, the number of pediatric cardiologists performing CMR exams is quite low, is the majority in most of the regions. Also in this table, you see that the places which have more pediatric cardiologists involved in the exams were the places which have a larger number of cases for a month, where the CMR complexity score was greater and where the CMR to surgery ratio was also greater. In conclusion, invest in people. Echo training needs to be specifically trained in pediatric echocardiography. A large number of exams are recommended and should involve a wide range of congenital heart disease. This training needs to be at a tertiary hospital with a congenital heart surgery program. CT training, there is no need to be a pediatric cardiologist. Be a friend of radiologist and help her him. That's my case. The CMR training is very similar to the pediatric echocardiographic training. Ideally, needs to be handled by a pediatric cardiologist, level 3, but this may be difficult in LMIC for several reasons. Thank you for your attention, and this is my email in case you need to contact me. Thank you.
Marcelo, thank you so much for that excellent overview. I think we're running a little behind, so I think we'll mush on. Our next speaker is Dr. Krishnan Iyer. I think he needs no introduction. He's going to speak to us on training surgical skills needed for open and closed cases or CHD programs in emerging low middle income countries. Dr. Iyer is the executive director in the Department of Pediatrics and Congenital Heart Surgery at Fortis Heart Institute in New Delhi. He has been a pediatric cardiac surgeon for over 30 years in India and has performed over 15,000 pediatric cardiac surgeries. He set up the first dedicated pediatric cardiac care program in India in 1995 at the Escorts Hearts Institute in New Delhi. He has been actively engaged in training pediatric cardiac surgeons from India and neighboring countries and has helped develop pediatric cardiac centers in this part of the world. He has focused on developing cost-effective, high-quality pediatric cardiac care that is feasible in developing countries. Currently, he's the president of the Indian Association of Cardiovascular Thoracic Surgeons and the Society of Pediatric and Congenital Heart Surgeons in India. He was the founding president of the Asia Pacific Pediatric Cardiac Society and the past president of the Pediatric Cardiac Society in India. He's an international member of the American Association of Thoracic Surgeons. He's also a member of the steering committee of the World Congress of Pediatric Cardiology and Cardiothoracic Surgery. So please, Dr. Iyer.
Thank you, Casey. Thank you for that introduction. And I'd like to thank the Congenital Heart Academy, especially Sasha and Grace, for the invitation to make this presentation. So as Casey mentioned, that my talk will essentially focus on surgical skills required for surgeons in LMICs. I have no financial disclosures, and my talk will largely be based on my experience in India and the neighboring countries, which of course are the most populous LMICs. About myself, Casey's already spoken. It's just by way of introduction, so people realize that I do have some experience in this field. I've been a full-time pediatric cardiac surgeon since 1990. I had my full medical education and cardiac surgical training in India, but I received a year's fellowship at the Royal Children's Hospital, Melbourne, 1989 with Dr. Roger Mee, and I came back to India to start one of the first neonatal and infant cardiac programs in the country. So far, I've worked in two institutions. The first was the All India Institute of Medical Sciences, where I did have my basic cardiac surgical training and my medical school. That's a leading university, which is governed by the central government. And I was there till 1995, till I moved to a private institution, that's the Escorts Heart Institute and Research Center, to start a dedicated pediatric cardiac program, which was one of the first dedicated full-time pediatric cardiac programs in the country. And over the course of this time, I have had an experience of over 15,000 pediatric cardiac surgeries, both from India and about 20 other countries. In the process, I've trained over 20 pediatric cardiac surgeons. These are full-time pediatric cardiac surgeons who now run programs of their own in India and in the neighboring countries. So my talk will essentially revolve around the experience that I have gained and the lessons that I have learned in the process of training pediatric cardiac surgeons over the last 25 years. This is the Fortis Escorts Heart Institute, the hospital where I started the pediatric cardiac program in 1995. So it's a little over 25 years old. This is in New Delhi in India. When we started, this building was only half its size, but it has grown over the course of time. It's a 300-bedded dedicated heart center. And we started the pediatric program, as I mentioned, in 1995. So what is different in LMICs as compared to high-income countries? And we'll look at it in medical and non-medical aspects. When you look at the medical aspects, one, of course, is there's a huge load of untreated patients. It basically stems from the fact that there's a huge disparity between the supply and the demand. As a result, your patients come with a wide age range. They can come as preterms to senior citizens. There's a wide range of pathology, from patients who are timely presenters to late presenters. And as a result, there's also a huge load of surgical emergencies. In some of the government hospitals, the hospital I worked there previously, we probably had 1 to 2 pediatric surgical emergencies every day. And then there is a high prevalence of bacterial, viral, and parasitic infections, along with varying levels of congenital heart disease, which add to the complexity of providing surgical care for these patients. When you look at the non-medical issues, then these are largely related to social as well as financial issues. Most programs are either in government hospitals, private hospitals, or in philanthropic institutions. But by and large in India, most of the pediatric programs are in the private hospitals. There is an income disparity amongst the patients. There are a few very rich who can afford almost anything. There's some middle class, but the vast majority of the patients are poor and can't really afford cardiac surgery. There's a resource crunch. The resource crunch largely centers around manpower. And of course, there's crunch of equipment availability and cost of consumables, because surgery has to be provided at ridiculously low costs. The government compensation for atrial septal defect closure or a VSD closure is $1,500, and you can go up to a maximum of $5,000 for a patient who requires a conduit repair or a valve replacement, and that includes the cost of the conduit and the valve. There's meager support, unfortunately, from government or even hospitals, because for the government, pediatric cardiac surgery is not a priority issue. And for most hospitals, because pediatric cardiac surgery is not remunerative, it doesn't generate any profits in the private hospitals, certainly the support from the hospital is not very encouraging. So it's generally the surgeon who is driving the program because he is keen on setting up a program, but unfortunately, the surgeon is held responsible for almost anything that goes wrong, be it a wrong diagnosis by the cardiologist or a wrong error or medication error by the nurse in the ICU. Anything that goes wrong, it is the surgeon who's held responsible. And ultimately, in private hospital, financial viability governs survival of the program, and it's the surgeon then who has to ensure that the program that he's running is financially viable at the end of the year, or the program closes down. So going on to the main topic of surgical skills, I'd just like to draw attention to a difference between what is surgical skills and what is a procedural ability. When we talk about surgical skills, these are the basic building blocks on which rests the ability of the surgeon to perform various surgical procedures. So this is the essential skills that surgeons, by and large, it's like the do-re-mi of music. So surgical skills are the basic building blocks. And they encompass not only those in the operating room, but skills outside the OR, which contribute to the successful outcome of an operation. The training focuses on imparting these basic surgical skills. Less importance given to individual surgical procedures, because once a surgeon has sound basic surgical skills, he can pick up any procedure very easily. And nowadays, you can even pick up these procedures by watching YouTube videos. So a surgeon in a low resource setting has to be more skilled than his counterpart in a resource-rich country, and I will explain why this is an essentiality. So why more skilled? A surgeon performing surgery in LMIC has to be quick and accurate. Why? Because he can't entirely rely on perfect cardiopulmonary bypass. It's a luxury to have cardiopulmonary bypass times of 4 hours and 5 hours because the complication rates escalate very rapidly. Secondly, surgery has to be accurate because any reoperations are extremely costly. And in most places, there is no backup of ECMO. So if the patient doesn't come out of the theater, then it's a death on the table. They frequently encounter diagnostic errors, and especially if you rely, as we mentioned in the previous talk, if you rely on echo reports from adult cardiologists, then you may get surprises on the table, and the surgeon has to be quick on his feet to change his course of action and to be able to deal with that surprise. The surgeon needs to compensate for the deficiencies of less trained support staff, which may be an anesthetist who is not proficient, a perfusionist who is not adequately trained in pediatric perfusion, and the surgeon needs to compensate for those deficiencies. And then, of course, there are challenges of late presenting pathology like polycythemia, pulmonary artery hypertension, and a simple VSD can become very difficult if you're operating at the level of borderline operability because of pulmonary vascular disease. And the most important problem is that in most institutions, most hospitals in the LMICs, there is no intensivist. So the surgeon has to be his own intensivist, or he may have to rely on support from an anesthesiologist or cardiologist. And in order to reduce his costs, he needs to anticipate and preempt complications, because every complication prolongs hospital stay and that escalates costs. So a surgeon in an LMIC may on one day have to do a neonate with an arterial switch or an obstructed TAPVC, and the next day may have to do an adolescent who's coming with severe polycythemia or severe pulmonary arterial hypertension, or an infant who's cachectic with a large ventricular septal defect, or another day may have to deal with a grandfather who for the first time has come to have his tetralogy fixed, and he also has coexisting coronary artery disease. So as I mentioned, the age range is very, very wide. Just an example of what a misdiagnosis can do. This is from a screenshot from a surgical discussion group that we have. Cardiac surgeons, pediatric cardiac surgeons in our country. We have a discussion platform on WhatsApp where we put up interesting cases or difficult cases, or the younger surgeons want advice on a difficult or challenging case. And this is just an incident which one of our surgeons put up. He operated a case which was supposed to be a large outlet VSD with severe mitral regurgitation due to atrial prolapse and a doming pulmonary valve. He went in for a VSD closure and a mitral valve repair. And on the table after stenotomy, found that this patient had an anomalous left pulmonary artery arising from the ascending aorta. So you have to change track and fix this in addition. Late presentation is a big problem. Just to give one example of some of the issues which would never be seen in the high-income countries. This is a case of child is 2.5 years old, weighs 7 kilograms. In congestive heart failure, has a huge liver and a pre-op central venous pressure of 16, and that's the X-ray. And this patient, what is the diagnosis? It's just a severe coarctation, and he undergoes a coarct repair, of course, with the regression of all this. But this is really advanced pathology. Or on a particular day, you may have a patient like this. This is a 4-year-old tetralogy who presented to us in the emergency in a stuporous rate with profound hypoxemia. Poor patients who had no money. So in addition to taking up this case for emergency surgery, we also had to raise the finances. But then we had an extremely encouraging outcome. This is the same kid 1 week after the total correction. So just an example of some of those challenges that you face in LMICs. Yet another case, which is from our colleague in Bangladesh, who also was trained in our unit. He just put up this the other day to ask, what should we do with this patient? Now, this is an 8-year-old girl who's got equal limb pressures, but with severe left ventricular dysfunction. And the CT shows that there's just one great vessel arising from the aorta, and the rest of the descending aorta is almost non-existent, all the way right down to the diaphragmatic surface. So what do you do with a case like this? So unusual pathologies are not uncommon in LMICs. So how do I train surgeons? The most important, of course, you have to teach by example. Students will not learn anything that you don't do yourself. The second most important ingredient is that passion for the work is absolutely essential if one has to have a career in pediatric cardiac surgery. Without passion, they will never ever succeed in this specialty. The training is a graded enhancement of skills over 2 to 3 years. They observe and they assist, and they do supervised surgery before they go on to do independent surgery. We teach our surgeons ICU skills. So during the day, they are in the operating room. During the night, they are in the ICU. They learn administrative skills because it's essential for them when they run units of their own. And they also have to learn communication skills, communication with parents, with the staff members, and also communication with the administration. Because if you're working in a private or a corporate setup, one needs to learn corporate language. It's important for them to network, have contacts within the country, outside the country. They also need to conduct outreach programs so that patients can be reached well beyond their own centers of practice. They also need to learn research, attend conferences, and take part in publications. And I usually insist that after the period of training with me, they go for 6 months to a year to an overseas unit to get a much wider exposure to the specialty and also see how things are done outside of the country. But most important, that they need to learn resilience and staying power, because when working in an LMIC, they're going to be brickbats thrown at you almost every other day, and they need to withstand that. When it comes to basic surgical skills, what are the basic skills that you start off with? Instrument handling, suturing techniques, vascular anastomosis. These are the crucial basic building blocks. Tissue handling is very, very important when you're dealing with small body technology, when you're dealing with neonates. The conduct of CPB is the next important aspect, and especially neonatal perfusion is extremely important because you can't leave this just to the perfusionist. Very often you've got to train your own perfusionist, so unless you understand bypass and anesthesia yourself, you can't do that for them. For a pediatric cardiac surgeon, this is a very important aspect. There's a mental 3D visualization of surgical repairs. When you're working on a collapsed cardioplegic heart, the structure is very different to what it will be when the heart fills up and beats. And so the essence of a good surgical repair is an accurate 3D rendering of this. And the surgeon has to visualize this in his mind before he starts the repair. The advanced surgical skills include individual surgical procedures. So how to do a Senning procedure, or how to do an arterial switch, or how to do a truncus arteriosus repair. These are the steps of individual surgical. But in LMICs, the most important aspect is when not to operate. So patient selection, as one of our earlier speakers mentioned, extremely important. If a patient is not suitable for surgery, not every congenital heart disease can be repaired. And in LMIC, it's important to know when a patient has reached a state of inoperability. So operation in the wrong patient not just leads to a needless mortality, but can lead to needless morbidity and prolonged hospital and ICU stay. This can be avoided. And then, of course, you also have to decide when to palliate a patient versus when to do a corrective surgery. Very often a patient may not really be suitable or may be high risk for a corrective surgery, may be palliated for a temporary period and be made more suitable for a future corrective surgery. So these are important lessons to learn, which are required in the LMICs. They also are taught ICU skills. And what are the ICU skills they learn? The placement of arterial lines, central lines, endotracheal intubations. All my surgeons are adept at this by the time they finish their training. They learn ventilatory strategies, weaning and extubating patients. They learn all about the pharmacological intervention in the post-op period, fluid management, asepsis protocols and antibiotic usage. And they learn basic bedside echocardiography, which means the ability to pick up ventricular function, pick up a pericardial collection, check for valve function at all. So you don't really have to depend on a cardiologist to come and check your repair in the postoperative period. What are the surgical procedures that they need to learn? Closed heart surgeries, PD ligation, quark repair, Blalock-Taussig, Thomas shunt, pulmonary artery banding, pericardiectomy. These are some of the common closed heart procedures that they need to learn. And the on-pump procedures with increasing level of complexity, simple repairs of atrial ventricular ASD and ventricular septal defect, TAPVC repair, tetralogy of fellow repair, repair of atrioventricular septal defects, then surgery for TGA, be it the arterial switch or an older patients with intact septum who come well beyond 6 months or a year of age. The Senning procedure is a procedure which is ideal for them. Repair of double outlet right ventricle and other conotruncal anomalies, conduit repairs, valve repairs. Single ventricle palliation by means of a bidirectional Glenn and subsequent conversion with the Fontan procedure, be it extracardiac or lateral tunnel, is added skills. But it's important that in LMICs, surgical procedures are prioritized because there's a large volume of patients and you can't really take care of all of them. And you have financial and other limitations in the program. And therefore, we look at what is known as the utility-futility ratio. Some operations are of extreme utility. Some operations are really futile. So for us, those which are of a high utility futility ratio are the biventricular repairs. So closure of all the defects, as I mentioned, as I've listed on the left hand, and those which are of a low utility futility ratio, like hypoplastic left heart syndrome, complex heterotrachesis syndromes, complex pulmonary atresia, major syndromic disabilities. These are procedures we discourage and we do not actively pursue. The guiding principles of the training is that we aim for 100% survival with low complication rates. Malnutrition, late presentation, other comorbidities should not be an excuse for poor outcomes. We've learned how to deal with them, and we have learned how to negate the impact of this as far as survival is concerned. Perioperative care has to be tailored to each patient's pathology and attendant risk factors. So each patient has to be analyzed with a view to what the potential complications can be, and they need to be addressed. And of course, attention to detail at each step is paramount to a successful outcome. Surgeons need to organize the workforce because workforce is limited to function efficiently so that multiple patients can be taken care of with a limited workforce. And most importantly, don't bite more than you can chew. Seek help and guidance without hesitation at any time of the day or night. So what can be achieved with limited resources? Our own program at Fortis Escorts to show we started in 1995 with small numbers, gradually built up the program to run up to 700 cases per year. The last couple of years have been hit because of COVID, so the numbers were down. But over the years, we maintained a steady outcome. The initial years were not very good in the start, but since 2001, we managed to maintain an operative mortality rate of less than 2%. In some years, it's been less than 1%. In 2020, despite the COVID crisis, which meant that we didn't do routine surgeries, 85% of our surgeries were emergencies, we still had an operative mortality of 1.48%. And this with just a team of 4 people, 1 surgeon, 1 anesthetist, 1 intensive care specialist, and a cardiologist. This is Dr. Srivastava, who was the founder cardiologist, has just retired recently. But we started the program 25 years ago, and we are still together. A lot of trainees come and go, but as far as the main consultants in the program, it is just the 4 of us. And this is how we started. This was in 1990, after return from Australia, the first arterial switch to be done in the country in August of 1990. And this is the same patient now at 30 years of age. He is a software engineer working in Toronto in Canada. 3 years later, we were able to do our first double switch in 1993. And this lady is now 30 years old. She had an arterial switch and a Seneng done at the age of 3 years for a CCTGA, intact septum and severe left AV valve. So to summarize, congenital heart surgery in LMICs is a different ballgame. Western models of training are a misfit in LMICs. Most surgeons have to be entrepreneurs and have to start programs from scratch. The ability to overcome odds and challenges on a day-to-day basis is key to winning the game. At the end, many surgeons in LMICs have shown that a lot can be done with very little in hand. But it's always a game of riding the high wire. Surgeons are always concerned when they're going to fall. But this is just to show what is possible with proper training and with proper application of the principles which I have enumerated. This is one of my early trainees who started a pediatric unit in the central part of the country. He's virtually a one-man army. He's a single surgeon. He doesn't have an intensivist. He has a part-time anesthetist. And he sent this picture of what his ICU looked like last week. And here you can see the array of cases that he has. There's an AVSD there, the Fontan here, a TAPVC here, an arterial switch here, total correction, another arterial switch, a truncus arteriosus, and another AVSD. He does 350 cases per year with a 98% survival. And these surgeries are done with an average cost of $2,500 per case on an average. So I will leave you with that. Thank you very much for your attention. Questions are welcome.
Krishna, thank you. That was just simply outstanding. I liked your comment that surgeons have to be his or her own intensivists. And I think you have the ultimate take. You actually married one. So I think that's a great answer to that. With that, that brings us to our final talk on CICU basics needed for congenital heart disease programs in emerging low-income countries. That's Dr. Parvati Iyer. I think she needs no introduction. She's at Forest Escort Hospital. She's the director of the Pediatric Cardiac Intensive Care Unit. I think she's literally one of my mentors. She taught me how to do prone ventilation years ago. Her areas of interest are low-cost innovations in the PCU quality control and accelerated nurses and resident module. So Parvati, please.
Thank you, Dr. Casey. And at the outset, I'd like to thank the Congenital Heart Academy and Dr. Grace and Dr. Sasha and all of you for giving me this opportunity to speak today on training of cardiac intensive care basics, which are needed for congenital heart programs and emerging or LMIC programs. I have really no disclosures to make, and a little bit about myself. I do full-time pediatric cardiac intensive care. My training background is that I've been trained both in pediatric and neonatal intensive care in Australia, largely at the Children's Hospital in Melbourne. I returned to India in 1994, where there were no opportunities and I was unemployed for a vast period of time. I joined Pediatric Cardiac Intensive Care Unit at the All India Institute, which is a public teaching hospital, because I really had no other job offers. But then I stayed on to do pediatric cardiac intensive care, and I joined Fortis Escorts Heart Institute in 1995 along with Krishna. And since then, I have been doing full-time pediatric cardiac intensive care since 1994. So I've really been one of the first in India, as well as in, I guess, in most low middle income countries, to spend a lifetime doing pediatric cardiac intensive care. And I have trained several intensivists. Some of them do intensive care. Some of them have given up intensive care. So really, the outline of my talk is I'm going to touch upon the cardiac intensive care basics, which are needed for congenital heart programs in high income countries or HICs. Who mans these intensive care units, and are the basics any different in LMICs, that is our part of the world, and who mans the CICU in our part of the world, and how do we train them? And this is really going to be a quick snapshot view, and what can be achieved with the kind of training that we deliver. A little bit about the COVID-19 era and the way forward as I see it. We all know that appropriate postoperative pediatric cardiac intensive care can optimize the benefits of a technically perfect surgery. Likewise, an inappropriate postoperative cardiac care can lead to unacceptable mortality in benchmark surgeries like ventricular septal defects and tetralogy of Fallot. We all know that a technically perfect surgery really means PD-accurate surgery with short pump times and cross-clamp times, and the utilization of TE or an epicardial echo to confirm the accuracy of the surgery. That's currently the standard of care. And wherever they are difficult to profile, VSDs or shunts, it's important to do a step up to look for them. The important message that I have is that we should not really leave the operating room with a significant residual defect, that is either a significant VSD or any fixed obstructions or any major anatomic issues. So broadly, the cardiac intensive care management in high-income countries, the perioperative cardiac care is really ideal. It's highly refined with a seamless continuity of care and based on multiple technological advances, leading to smoother and far more efficient management of extracorporeal life support, VAD, expedient ECPR, hyperplastic left heart syndromes, complex univentricular physiologies, and various stage surgeries and interventions. So there is really a lot of glamour and excitement in the successful management and heroic salvage of sick infants with complex problems. Dr. Anthony Chang said that postoperative cardiac intensive care is really a wonderful clinical milieu, which is inherently attractive for its near unique combination of an interesting myriad of pathophysiological puzzles and a constant exposure to technological advances. So do we really need special skill sets or special training for congenital heart programs in the high-income countries? Yes, you do, because you need to meet the unique needs of neonates and infants with complex heart disease who have very often concomitant pulmonary hypertension with unique univentricular physiology, restrictive cardiac physiology. So in most high-income countries, about half of them are cardiac neonates, and increasingly preterm infants undergo complex cardiac surgery. So there's very much a need for a dedicated pediatric cardiac intensive care unit with very special skill sets. And this emerged as a distinct specialty in the United States in 1990. And a lot has been written by the task force on requirements for pediatric cardiac critical care, as well as the requirement for the trainees. But even today, there's huge variability in training needs and pathways, both in the United States and Europe. And the grid entry into the United Kingdom varies from a duration of between 4 to 8 years. And the bottom line is there's a huge focus on competencies and various intensive care procedures. So who mans the CICU in high-income countries? There's layers and layers of highly skilled personnel. I was told that they're very often a senior fellow training in pediatric cardiac intensive care unit, pediatric cardiac intensive care, closely supervised by a consultant or an attending 24/7. And many are double boarded. That is, they have training both in pediatric cardiology as well as in intensive care. And they are supported by specialized nurses, physician attendants who are also equally well trained. There's a lot of 1:1 nursing. There's a huge focus on magnet designation of nurses. And the goals are higher and higher levels of individualized care with a focus on patient and family-centric care. So really, there is very little scope for error. So now what happens in our part of the world? Are the basics needed any different? A lot of the basics needed, like techniques of ventilation, etc., are pretty universal, but many are very relevant only to our part of the world. And this is related to patient profile and presentation. So I'm going to now touch upon our institute, that's the Fortis Escorts Heart Institute, and my experience here as a solitary intensivist and our 27-year-old journey. So you've seen some of these slides which highlight a very different scenario in our part of the world, with a lot of polycythemic tetralogies, a lot of cachectic large left to right shunts, and our own unique challenges where you have a lot of adult congenital heart disease and some with coexisting coronary artery disease. But what is commonplace is a lot of concurrent chest infections and pre-existing and recent chest infections, which prolong postoperative ventilation. And very often they're postoperative ventilatory challenges, which really defy cardiopulmonary interactions such as this. And there's a lot of coexisting past tuberculosis. Many of the infants are sick and complex, and those with transposition, total anomalous pulmonary veins, and ALCAPAs not infrequently present with systemic ventricular dysfunction, pulmonary hypertension, and presentation with circulatory collapse and organ dysfunction is not infrequent, all of which contribute to substantial postoperative severe low cardiac output state. And in addition, as we do more neonates and small infants, we have seen occult or evolving preoperative multi-drug resistant gram-negative as well as fungal sepsis. And the implications of all these is not just in terms of huge financial cost, but also horrific postoperative mortality and morbidity. So effectively, in our part of the world, the challenges are many. And apart from late presentation, it includes concomitant problems and a whole host of comorbid factors, which in many cases includes hepatitis-associated HIV, malaria, and dengue. So the potential for postoperative complications are myriad. They're varied and greatly increased, and intensive care potentially is daunting, varying, and could be more expensive. So what is the role of the intensivist here? It's apart from early detection of problems and the coordination of postoperative management, also conflict resolution is one of continuous innovation and continuous ongoing innovation. So who mans the cardiac intensive care unit 24/7 in our organization? This has been changing with the times, and it's very important to keep changing as times go by, depending upon the milieu. And increasingly, interestingly, it is manned by not more skilled personnel, but by more unskilled personnel. Initially, we had pediatricians and pediatric fellows who were interested in pediatric intensive care or cardiac intensive care, who were supported by nurses and very senior nurses with a lot of increased experience up their sleeve. Now, 27 years later, we've come full circle. Our intensive care unit is manned by surgeons with the help of 2 MBBS residents. It's largely a nurse-based intensive care unit, but with increasingly inexperienced or novice nurses who are fresh out of nursing school. Now, is this possible to cope, and can we manage this long-standing? We are going to now look at that. Now, about a decade ago, in 2011, 10-bedded cardiac intensive care unit and a 10-bedded step-down unit with 15 low dependency beds, who service 600 surgeries per year, were manned by 1 pediatric attendee and through pediatric residents. And really, we found that less than 20% were interested in an intensive care career. A year later, we'd moved to more than 700 surgeries per year. And what we found was there was a huge and perennial shortage of pediatric doctors to do on-calls. So we had to rope in surgical residents to do intensive care units, and they were taught how to shift gears and work in multiple complex environments. A way forward to 2017. So we now increased our intensive care beds. So 15 bedded intensive care, 10 step-down beds, and 16 low dependency beds. Pediatric residents became increasingly scarce, and we can discuss why that is so. And so surgeons then had to operate during the day and then man the intensive care unit by night. So the cardiac intensive care unit was often unmanned during the day with only young novice nurses, and supported by medical interns who were very inexperienced. They're not even pediatricians, but they're just fresh out of medical school, but incredibly enthusiastic. So what do we do to teach and train all of them? And that's been our priority, is to teach many of them to recognize evolving problems, whether they're novice doctors or novice nurses, and more important, to call for help on time. And if no help arrives, to do a blood gas if possible and commence cardiopulmonary resuscitation. We also teach them to handle the authority gradient effectively. That is very often sometimes as an experienced nurse versus a novice resident. And most important of all, to avoid conflict within the unit. This is the kind of modified pediatric early warning score, which is pasted everywhere, which really helps inexperienced nursing and medical staff to identify potentially sick patients. Now, the current role of an Indian nurse is very diverse, and it's ever expanding. They're taught to recognize arrhythmias, not at least complex, potentially lethal arrhythmias, and most of them have become proficient at resuscitation. This is despite their role as a maternal educator and maternal support system. The key principles of our cardiac intensive care training include a meticulous care plan, follow early warning signs to predict adverse events, a rapid response to that, and somehow to survive a shift. There's a lot of positive reinforcement provided and encouragement, and the main carrot has been that we support decisions for their growth and movement to high-income countries. So this is the kind of care pathway or protocol that we have, which is highly anticipatory and multi-pronged, which involves ventilation, hemodynamic support, nutritional support, and various other strategies. Our training is pretty fast-tracked, and our main focus is to somehow learn to survive a shift. So the approach is highly preemptive and based on very broad guidelines and a clear-cut anticipatory plan for each patient before they come from the operating room. This is the kind of a care pathway, to give you an example, to our approach, which is systematic and highly protocolized to the management of postoperative left ventricular failure or systemic ventricular failure. Likewise, our approach to pulmonary artery hypertension, systematic, diverse, but again based on basics. Pediatric cardiac intensive care is unfortunately an unforgiving specialty. So it's very important to reduce error rates and potential complications by the use of protocols and checklists in an effective manner. How we do this is our information handover is written on a whiteboard, and all the care plans are written so that nothing is really missed out. Nurses are also encouraged to be involved in protocols, and this is a nurse-driven protocol, which is our carefully evolved feeding protocol for sick infants and babies so they do not get necrotizing enterocolitis or abdominal pathology. Now, what about the challenges which are faced by our trainers? Because there are very few skilled and experienced nurses and nurse trainers, is to see that that we have shorter and shorter nurse learning curves. So impromptu classes are held whenever there is a free moment, and apart from patient care management, soft skills are also inculcated into them. One of the important messages that we teach is methods to avoid conflict, when and who to ring in times of trouble, because there's a huge skill mix which causes further confusion, and we teach them how to handle the authority gradient in a graceful manner. Yet other lessons which are taught is the importance of effective communication and to avoid mitigation in the intensive care unit, and a cockpit style checklist for error control. This is from the book by Malcolm Gladwell on the ethnic theory of plane crashes, and it is very, very important to teach young, inexperienced staff to avoid mitigation, and we teach them to learn to say, please come now, we need help now, not to say, oh, things are okay, or things are not too bad, or a little better now. It's been well established in Western literature that poor communication is an important cause of mortality and morbidity. Some of the other lessons that we teach them are the urgent and the important, the difference between them, and to make swift decisions in a complex milieu. They're all wearing masks because this is a COVID time. Other issues that they have to learn with are unexpected power failures which occur in our part of the world, and how to avoid bedlam in this atmosphere. It's very important that we keep junior doctors and nurses working and learning together, and we conduct mock drills in a supporting atmosphere. There's no room for adversarial relationships. So these are pictures which illustrate surgeons, physicians, nurses learning and growing together. But our system is far from perfect. It's a very lean and a delicate system, and errors do continue to occur, unfortunately. So then it's important to have a system where you solve problems in unison. It is not reasonable to expect perfection, especially in our part of the world, but it is very reasonable to ask that we never cease to aim for it. And that is what we encourage and support, that you struggle to try and achieve perfection, if nothing else. You've all seen this 25-year mortality trends, and what I'd really like to highlight is, despite the fact that we've hardly had any intensive care physicians, and most of the surgeons have been doing the intensive care for the last couple of years, our 30-day outcome has been more than satisfactory. And the last year, 85% were really infant and neonatal emergency surgery, again, fairly gratifying outcomes. So to sum up, our unit at the Fortis Escorts Heart Institute has been a giant roller coaster ride. We often need to change gears frequently. And the important thing that I've learned over the years is to try and teach people to enjoy this bumpy ride. Now, the COVID-19 era, unfortunately, has brought a lot of challenges. It's also brought tragedy and havoc on our very fragile healthcare system. There's been a lot of death and disability among young doctors and nursing staff. We have further enhanced attrition of an already dwindling workforce, and this has been further compounded by migration and movement to manage positions by medical and nursing staff who are terrified of this virus. And many of our specialty hospitals, including our own hospitals, we had to treat COVID-19 patients at highly subsidized cost. So there's been tremendous depletion of our hospital funds. Patient subsidies have become very difficult. There is increased parental unemployment and death of a lot of our parents, which has reduced further parent affordability. So the future challenge will include the need to further subsidize pediatric cardiac care, but without reducing the bar or the quality of care. So what is the way forward that I foresee in post-COVID times? I mean, we are alluded to as a lost generation, is that we have to depend upon very low-cost pediatric cardiac care, as low as is feasible. And we manage with small, highly focused teams who are not too expensive to maintain and sustain, who also have the ability to multitask and who are not necessarily formally trained as perceived by Western models of training. So to conclude, the future for low middle income countries, we recommend a versatile approach which is flexible based on very small cohesive teams using a fast track training module where the training is simplistic, practical, bedside, on the spot, highly anticipatory, but factoring in speedy attrition rates of the personnel based on meticulous care plans, a highly anticipatory approach, and multiple mock drills. I'd like to thank you all for your time and attention. And thank you again, Dr. Casey Culbertson, for thinking of us. Thank you.
Thank you, Prabhati. That was just excellent. And I'd like to, I know we're a little over on time. I'd like to thank all the presenters and all the participants. And I'm going to defer to Grace and Sasha as to how you want to do the panel discussion.
So as we are a little bit late, I don't think we're going to be able to do a lot of the pool. We had prepared a lot of questions for the audience to make the discussion to be funnier, but I think as we are a little bit ahead of time, we won't be able to do all of that, but we can do some. I just, for us to start with, I'd like to ask Dr. If it's okay with you, Casey, if Dr. Ihsan could tell his experience on his cardiac program, including an ECMO, as he's with us as a panelist.
Well, hello everyone. I loved your talk, Grace, about how you initiated your ECMO program in Brazil, and I really lived what we did when I was listening to you. Jana did everything for us, your friend. I agree with you. It's not money. It's just knowing what you are doing, having the proper person, knowing what she or he is doing on an ECMO patient. This is vital. And then you have to build up walls. Jana built walls just to protect us, to protect the patient, and to protect us from abusing ECMO. You know, you can put any dying patient on ECMO. We had this experience with the adult side. Every patient now had an ECMO before dying a few days later. In pediatrics, we protected ourselves. This is very important, to know what you are doing and to protect yourself with some walls and protocols.
Sure, I agree. And then it would be a waste of money. If you place on ECMO patients who has a very low likelihood for survival, then you abuse the system, you make the team to be sad and think that ECMO is not worth it, and the families and the money from that you could use in a better way. Thank you for your participation. Thank you very much.
So I just wanted to add, I think that's an excellent comment. When I first got to Vietnam, one of the first questions I asked is, can we get an ECMO machine? And I said, no. You need an echo machine because then you avoid ECMO. So I think it was an excellent comment. And Sasha, I want you to stand up and show off your t-shirt.
Yeah, is, huh? No, I think that, you know, when we start with this meeting, Casey, I told you excited because we know everything what's up in US rather than in Europe, but we really miss. And what you did in Vietnam, I think is more than, you know, open a center in Europe or USA, because I think that the most important point from medical point of view is the culture to arrive at 7 in the hospital, to stay up to the night when the patient doesn't go well, to follow all the complex case up to the patient is discharged. This is, as you say, you learn from them that 3 times is not more, you need probably 4 times to complete the information, but they took from you the example. We learned this with Gil, he talked about Professor Castaneda, and I think as all these people doing in this country, they are driven by example. And when you are there, you are for them an example. And this is very important because you must be able to manage complex death of the patient, refuse one case. And this is for them something that is not easy to learn. And I agree 100% with you. You can accept training people in your center, but they have to work in his field, in his country. And this is not easy. This is, I think, that is the most difficult things.
Well, I think we live in a great culture and a great specialty where we can learn from each other quite easily. I think we have the right mindset to do that. I think talking about that there's no real gradient in an ICU, that everybody has kind of an equal voice, I think is just a really important point.
Yes.
Okay, very nice. I'd just like to okay, sorry, Sasha.
No, I want to know about the Indian experience, because I think that they are facing the worst situation of the world. So if Professor Iyer and Parvati, they can comment about what was before and what is now, and how big was the work about this.
Is it about the number of patients who come? Well, the affordability has substantially reduced because many fathers have died. There are people who have lost jobs, and the insurance companies, very often the insurance is linked to the job. So we have to subsidize, and we have to try and do more and more with actually less and less. So things are not good, and we don't see things getting a lot better in the next few years to come. So that's why we need to be more efficient.
Indeed, indeed. It was a very nice session. We have some questions on the Q&A chat box. I think we could go through.
I loved one question about how to stop the brain drain in developing countries. I think somebody, Dr. Nurul Hassan asked it, how to stop the brain drain, how to convince the hospital administration that a good intensivist or surgeon is important, how to keep this person. I have the same problem, so maybe my fellow panelists can answer this.
Yeah, I've experienced the same thing. Several great intensivists that we trained and thought would go into other programs, just because they have young families, they have several kids now over the course of years. They've gone out into private practice because they just can't afford, I mean, as much as they like to stay at the government hospital, they just can't afford to be there. So I wish I had an answer, but I really don't. I think it's a problem everywhere.
In India, yes, doctors do move, but fortunately in the last many years, the doctors are not moving out of India to do either cardiac surgery or cardiology. The nurses are moving, the well-trained nurses, and they are very well paid overseas. And after being trained very well in pediatric cardiac intensive care, I know nurses who are moving to UK and US to work in an senior citizens' home, simply because they're paid 10 or 15 times more. And I think there are no easy answers to that. And I mean, in my own opinion, I think if they need to go, they need to go, because they have to look after their young families. Fortunately, we are a country, despite COVID deaths of more than 1 billion. So we have many more to train, So we just keep training the fresh lot as we go along.
Okay, we want to close this session, Grace, and we ask Casey to make a sort of final.
Just want to say thank you to all of you and for attending and for these amazing speakers and panelists. Thank you, guys.
Thank you for organizing it and inviting us. Thank you very much.
Thank you so much.
Thank you so much, Grace.
Thank you, everybody.
Everyone.
It was a pleasure.
Casey, thank you very, very much. You did great. Thank you.
Good to see you all, and stay safe.
Yeah. Casey, please, we have to continue with this.
Yeah, oh, absolutely. I think there's more people to talk. But I want to thank all the participants, because you guys are just awesome. Parvati, you got the ultimate compliment from one of my Vietnamese colleagues who texted me in the middle of your talk saying, "She is just awesome." So there you go.
Thank you.
Very good.
So thank you, both of you.